Analgesics. Analgesics are drugs that relieve pain without significantly altering consciousness. They relieve pain without affecting its cause. Analgesics can be opioid or non opioid. Opioid analgesics. Morphine is the most important alkaloid of opium, the dried juice obtained from the capsules of Papaver somniferum. Opium contains many other alkaloids. The term opiates refers to drugs derived from opium poppy, whereas opioid analgesic applies to any substance which produces morphine like analgesia. Classification of opioids. First, opioid agonists, which are further subdivided into natural opium alkaloids, semi-synthetic opiates, and synthetic opioids. Second, opioid agonist antagonist, and third, partial mu receptor agonist and kappa receptor antagonist. Opioid receptors. The three main types of opioid receptors are mu, kappa, and delta receptors. Opioid agonists. Mechanism of action. Morphine and other opioids produce their actions by interacting with various opioid receptors, mu, delta, and kappa. They are located at spinal, supraspinal, and peripheral nerves. Morphine is the prototype drug. Pharmacological actions of morphine. Morphine has mainly CNS depressant effects but also has stimulant effects at certain sites in the CNS. In the CNS, the depressant effects are: first, analgesic effect, mediated mainly through mu receptors at spinal and supraspinal sites. It is the most important action of morphine. At the spinal level, it decreases release of excitatory neurotransmitters from primary pain efferents in the substantia gelatinosa of dorsal horn. The excitability of neurons in dorsal horn is decreased in the supraspinal level. It alters transmission of pain impulses. It is a very potent and efficacious analgesic. It causes sedation, drowsiness, euphoria, makes a person calm, and raises the pain threshold. Perception of pain and reaction to it are altered by these drugs. Moderate doses of morphine relieves dull and continuous pain, whereas sharp, severe, intermittent pain such as traumatic or visceral pain requires larger doses of morphine. Opioids also act peripherally to alter the sensitivity of small nerve endings in the skin to painful stimuli associated with tissue injury or inflammation. The second depressant effect is euphoria, which is the feeling of well-being. It is an important component of analgesic effect. Anxiety, fear, apprehension associated with painful illness or injury are reduced by opioids. The third depressant effect is sedation. Morphine in therapeutic doses causes drowsiness and decreases physical activity. Fourth is respiratory depression. It depresses respiration by a direct effect of the respiratory center in the medulla. Both rate and depth are reduced because it reduces sensitivity of the respiratory center to CO2. Respiratory depression is the commonest cause of death in acute opioid poisoning. Cough suppression. It has a direct action on cough center in the medulla. Hypothermia. In high doses, morphine decreases temperature regulating center and produces hypothermia. The stimulant effects are: first, miosis. Morphine produces constriction of the pupils due to the stimulation of third cranial nerve nucleus. Some tolerance develops to this action. Pinpoint pupils are an important feature in acute morphine poisoning. Miosis is not seen on topical application of morphine to the eye. Second, nausea and vomiting. It is due to the direct stimulation of the CTZ in the medulla. 5-HT3 antagonists are the drugs of choice to control opioid-induced nausea and vomiting. Third, vagal center. It stimulates vagal center in the medulla and can cause bradycardia. Other effects are physical and psychological dependence. Repeated use of opioids causes physical and psychological dependence. The effects on CVS. Morphine produces vasodilation and fall of BP. It mainly causes vasodilation of peripheral vessels, which results in shift of blood from pulmonary to systemic vessels, leading to relief of pulmonary edema associated with acute left ventricular failure. On GIT, it causes constipation by direct action on the GIT and CNS, decreases GI motility, and increases tone of the sphincters. In urinary bladder, it may cause urinary retention by increasing tone of urethral sphincter. On biliary tract, it increases intrabiliary pressure by increasing tone of sphincter of Oddi. Histamine release. Morphine is a histamine liberator and causes itching, skin rash, vasodilation, bronchoconstriction, etc. Pharmacokinetics. On oral administration, morphine is absorbed slowly and erratically. It also undergoes extensive first pass metabolism. Hence, oral bioavailability of morphine is poor. Morphine is commonly administered by IV, IM, or SC routes. It can also be administered by oral, epidural, or intrathecal routes. It is widely distributed in the body, crosses placental barrier, and is metabolized in liver by glucuronide conjugation. Morphine 6 glucuronide has more potent analgesic action than morphine and is excreted in urine. Adverse effects are nausea, vomiting and constipation, respiratory depression, hypotension due to vasodilation, drowsiness, confusion and mental clouding, itching, difficulty in micturition, respiratory depression in newborn due to administration of morphine to the mother during labor. Drug tolerance develops to most of the effects of morphine. Drug dependence is the main drawback of opioid therapy. Psychological dependence is associated with intense craving for the drug. Physical dependence is associated with the development of withdrawal symptoms. When administration of an opioid is stopped abruptly, the symptoms and signs are irritability, body shakes, yawning, lacrimation, sweating, fever, diarrhea, palpitation, rise in BP, loss of weight, etc. Dependence is mediated through mu receptors. Treatment of morphine dependence: hospitalization of the patient, gradual withdrawal of morphine, substitution therapy with methadone. Pure opioid antagonist like naltrexone is used after detoxification to produce opioid blockade to prevent relapse in patients who have a sincere desire to leave the habit. Acute morphine poisoning is also an adverse effect. The characteristic triad of symptoms are respiratory depression, pinpoint pupils, and coma. The other signs and symptoms are cyanosis, hypotension, shock, and convulsions. Death is usually due to respiratory depression. Treatment of acute morphine poisoning: hospitalization, maintaining of airway, breathing, and circulation, ventilatory support, gastric lavage with potassium permanganate. Specific antidote is naloxone, 0.4 to zero point 0.8 milligram intravenously. Dose is repeated till respiration becomes normal. Naloxone is a pure antagonist, competitively blocks opioid receptors and rapidly reverses the respiratory depression. Contraindications are head injury, bronchial asthma, COPD, hypotensive states, hypothyroidism, undiagnosed acute abdominal pain. Codeine, natural opium alkaloid. Codeine has analgesic and cough suppressant effects, is administered orally. Compared to morphine, it is less potent and less efficacious as an analgesic. It has less respiratory depressant effect. It is less constipating. It has selective cough suppressant effect, hence used to suppress dry cough. It potentiates analgesic effects of aspirin and paracetamol. Codeine is used for relief of moderate pain. The main side effects are constipation and sedation. Pethidine or meperidine. Pethidine can be administered by oral, intravenous, subcutaneous or IM routes. It is well absorbed from the GI tract, but bioavailability is about 50% because of first pass effect. Widely distributed in the body, crosses placental barrier and is metabolized in liver. The metabolites are excreted in urine. The adverse effects of pethidine are similar to those of morphine. It can cause tremors, hallucinations, muscle twitches, and rarely convulsions due to its metabolite, norpethidine. Tolerance, physical, and psychological dependence can also develop with pethidine. Diphenoxylate. It is a pethidine congener and is used in the treatment of diarrhea. It is available in combination with atropine. It is rarely used at present because of its side effect, paralytic ileus. Loperamide. Loperamide is a pethidine congener. It reduces GI motility and secretions but increases the tone of the anal sphincter. It is used in the symptomatic treatment of diarrhea. Common side effects are constipation and abdominal cramps. Therapeutic uses of opioids. First, as analgesic, morphine and other opioids are potent and efficacious analgesics, hence used for moderate to severe painful conditions such as acute myocardial infarction, burns, pulmonary embolism, fracture of mandible and long bones, bullet wounds, etc. Second, pre-anesthetic medication. Opioids like morphine and pethidine are used about half an hour before anesthesia. Because of their sedative, analgesic, and euphoric effects, the dose of anesthetic required is reduced. Third, acute pulmonary edema. Intravenous morphine relieves breathlessness associated with the left ventricular failure due to pulmonary edema by reducing preload on the heart by peripheral vasodilation, shifting blood from pulmonary to systemic circulation, reducing anxiety, fear, and apprehension associated with the illness. Fourth, post anesthetic shivering, in which pethidine is effective. In cough, codeine and dextromethorphan are used for suppression of dry cough. In diarrhea, synthetic opioids such as loperamide and diphenoxylate are used for symptomatic treatment of diarrhea. Tramadol, it is a synthetic codeine derivative with weak agonistic activity at mu receptors. It also inhibits the reuptake of noradrenaline and serotonin. Tramadol causes analgesia, respiratory depression, physical and psychological dependence, nausea and vomiting, euphoria, constipation and sedation. Fentanyl. It is a synthetic opioid with a potent mu agonistic effect. Pharmacological actions are similar to morphine. L-fentanyl, sulfentanyl, and remifentanil are short-acting fentanyl analogs. They are useful for short procedures where intense analgesia is required. Methadone. It is a synthetic opioid with agonistic effect at mu receptors and has a long duration of action. Pharmacological actions are similar to morphine. They are meiosis, analgesia, respiratory depression, physical and psychological dependence, nausea and vomiting, euphoria, cough suppression, constipation and sedation. Dextropropoxyphene. It is structurally similar to methadone. The side effects are nausea, constipation, sedation, abdominal pain, etc. It may cause cardiotoxicity and pulmonary edema. Opioid agonist, antagonist, and partial agonist. Pentazocine. Pentazocine is an opioid agonist antagonist. It has agonistic action at kappa and weak antagonistic action at mu receptors. At low doses, its pharmacological actions are almost similar to that of morphine. In higher doses, causes sympathetic stimulation. It causes analgesia, respiratory depression, physical and psychological dependence, nausea and vomiting, constipation, biliary spasm. Side effects are sedation, nausea, vomiting, respiratory depression, hallucinations and nightmares. Tachycardia, palpitation and rise in BP are seen with high doses. Buprenorphine. It is a partial mu receptor agonist and kappa receptor antagonist. Is about 25 times more potent than morphine as analgesic. The pharmacological actions are qualitatively similar to morphine, but it has a delayed onset and prolonged duration of action. It can be administered by parenteral and sublingual routes. It causes meiosis, analgesia, respiratory depression, physical and psychological dependence, hypotension, nausea and vomiting, euphoria, constipation and sedation. Opioid antagonist, naloxone, naltrexone and nalmefene. They are pure opioid antagonists. These drugs have no agonistic activity. Naloxone, naltrexone and nalmefene competitively reverses the effects of both natural and synthetic opioids, but do not completely reverses buprenorphine induced respiratory depression. Naloxone also blocks analgesic effect of placebo and acupuncture and effects of endogenous opioid peptides. Naloxone is orally not effective because of high first pass metabolism. It is short acting. On IV administration, it immediately antagonizes all the actions, especially respiratory depression, of morphine and other opioids. Intravenous naloxone precipitates withdrawal symptoms in morphine and heroin addicts. Use of naloxone. Main therapeutic usage of naloxone is for treatment of morphine and other opioid poisoning. In the treatment of opioid overdosage, intravenous naloxone rapidly reverses respiratory depression induced by opioids. To treat neonatal asphyxia due to use of opioids in the mother during labor. Uses of naltrexone. Naltrexone is orally more potent and has longer duration of action than naloxone. Naltrexone is used for opioid blockade therapy to prevent relapse in opioid dependent individuals. It is also used for the treatment of alcoholism as it reduces the urge to drink. Methyl naltrexone, a derivative of naltrexone, has only peripheral actions. It can be used for treatment of constipation due to opioids. Nalmefene. It is administered intravenously. It is longer acting than naloxone, useful in the treatment of opioid overdosage. Endogenous opioid peptides. Endorphins, enkephalins, and dynorphins are naturally occurring substances present in the brain and other body tissues. They are called endogenous opiates because they resemble opium alkaloids in their actions. These peptides appear to be involved in placebo and acupuncture induced analgesia. Thank you.